clinical swallow evaluation is a preliminary assessment for swallowing status. The first step includes a case history and oral MEC exam. Then, the client is tested on various liquids and foods as appropriate for the client's safety. This evaluation helps to determine the need for an instrumental exam, such as an MBS or FEES. The following items are needed for the clinical swallow evaluation: gloves, tongue depressor, pen light, cups, straws, spoons, ice, water, pudding or applesauce, crackers, thickeners, and napkins. During the exam, you are assessing the patient's feeding and oral skills. For example, look for the patient's ability to open and close his or her mouth, their ability to maintain lip closure, and ability to clear the bolus from the oral cavity. You are also seeing if the patient can maintain an upright position and making note of their respiration patterns. For example, is the patient coordinating their breathing during PO trials? Take note of the patient's swallow initiation, timing, and hyolaryngeal elevation and excursion by palpating the larynx. Also count the number of swallows per bolus. 1 swallow should be sufficient for liquids, 1 to 2 for soft, moist foods, and 2 to 3 swallows for dry, thick foods. Keep in mind potential pathophysiologies of observed symptoms. For example, if a patient is unaware of his or her drooling, this may indicate sensory deficits. After completing the medical history form, the clinician administers the oral MEC exam. The clinician is assessing the client's range of motion, strength, symmetry, coordination, and sensation of their oral structures. The articulators that will be assessed are the mandible, lips, tongue, velum, and dentition. Additional information can be obtained through the oral MEC exam, including dysphonia, dysarthria, breath support, resonance, cough, secretion management, and if the patient complains of facial numbness and or tingling.
I'm going to have you put your tongue to each side like this. All the way as far as you can. That way. Good. Now touch your nose. Touch your chin. Okay. Now pucker your lips like you're going to kiss. And I'm going to try and pull your lips wide apart. Don't let me. Let's see your that lip strength. Good. Now open your mouth. I'm just going to check out your teeth, how everything's looking in there. Say ah, 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 ah. Good. Okay. Now I'm going to touch your face. Point to different spots on your face. Just point where you feel me touch, okay? Very good.
Step 2. The client is asked to do a saliva swallow if deemed necessary.
Now I'm going to have Jamie do a saliva swallow. I'm going to check for hyolaryngeal elevation and excursion by placing my finger in her hyothyroid space. I'm also going to have her say ah at the end of her swallow to check to see if there's any pooling of saliva. Okay. So Jamie, I'm going to place my hand right here. It shouldn't feel uncomfortable. Swallow when you're ready and then say ah. Ah.
After each trial, the clinician should assess the patient's voice by having the patient sustain ah following each swallow to check for a wet vocal quality. If the client is doing well, have the client partake in multiple trials to ensure consistency. The clinician should try using compensatory strategies if the client is having difficulty. It's important to ask the client what they feel to check for sensation. The clinician should inspect the client's mouth following the swallow during solid food trials to assess the amount of pocketing. If the patient experiences many signs and symptoms of aspiration, the clinician should stop the per-oral trials immediately An immediate referral for an instrumental study may be warranted based on the client's candidacy for therapy and willingness to follow directions. Next, the client is asked to swallow ice chips.
Okay, Jamie, now I'm going to have you swallow the ice chip. And right after you swallow, say, ah. Great.
During step 4, the client is asked to swallow water via spoon, cup, or straw. Thickened liquids such as honey or nectar thick may be used if the patient fails on thin water.
Okay, Jamie, now I'm going to have you drink some water. And same as always, I'll just have my hand on your neck. Swallow when you're ready. Say ah. Good.
Step 5 includes food trials such as pudding or applesauce.
Okay, now I'm going to have you take a little bite of applesauce. So I'll just have you scoop up about a half a spoonful. Should be good. Yeah, looks good. Okay, and same thing. Say ah right afterwards.
Step 6 includes soft chewables such as a cracker, or hard chewable items can also be used. The clinician needs to keep in mind that progression through the hierarchy depends on many factors, such as the patient's level of aspiration and safety. If the client does not experience any difficulty, the clinician can increase more complex consistencies.
Okay, Jamie, now I'm going to have you take a bite of cookie. Same thing. Say ah afterwards. Good. Okay. I didn't hear anything in the voice that would make me think that you have anything down there.
Mm-mm.
But I felt about 2 swallows.
Yeah.
Did you feel like it took about 2 swallows to
Yep.
clear that?
I would say
Okay.
2 swallows.
Okay. And does anything feel like anything sticking around in your throat?
Not really. Mm-mm.
Okay. Good.
During each trial of the various consistencies, the clinician is aware of potential signs and symptoms of penetration or aspiration. For instance, the patient may exhibit coughing, throat clearing, wet vocal quality, respiration changes, shortness of breath, or a potential drop in oxygen levels. The limitations to the clinical swallow evaluation are that it is very subjective and not reliable for identifying aspiration, which is why it's important to refer the patient for an MBS or FEES exam. A FEES may be recommended for a patient if positioning in the fluoroscopy unit is problematic, transport to an X-ray department is also problematic, the patient has severe dysphagia with a very weak or potentially absent swallow reflex, post-intubation and laryngeal trauma are suspected, the clinician needs to assess the patient's fatigue over a meal, the patient needs repeated exams in a short period of time, the patient could benefit from visual feedback to learn maneuvers, the patient has hypernasality or dysphonia, or the patient is having difficulty handling secretions. An MBS may be recommended if the patient will not tolerate a FEES, there is a suspected oral or esophageal stage problem, the patient complains of globus, there is a need to identify which bolus propulsion force is weak, there is a suspected aspiration during the swallow, and/or the clinician needs a better impression of the amount of aspiration.